So we went live in terms of the facility in 2015. That was about 1 year and a half ago in a new hospital called Ng Teng Fong, and it's connected to a community hospital. So we have 700 acute beds and 400 community hospital beds. So this was the first integrated project that the Ministry of Health embarked on, and we were the so-called guinea pigs. And it's actually a good experiment, because now when we do cases on hip fractures or any acute surgery, we can transfer them to the community hospital in a seamless fashion. And the doctors on both sides are from the same company, so we actually see the patients very efficiently. So the outline of the talk would be on the overview of the Ministry of Health healthcare public system, challenges in our healthcare in Singapore, and I think it's very similar to the challenges that you are facing in Thailand and in the region. The Jurong campus IT system, we call ourselves Jurong campus because we've been merged with the National University Health System now, so our so-called company is called National University Health System. The role of IT and how we've used IT to provide safe care and quality care, and a real-life example of what happens when mistakes are made in IT and how we are still recovering, and a summary of all these points. So this is just a video of how the healthcare clusters are done in Singapore. So currently there are now, well, just a month ago, there were actually 6 healthcare clusters in Singapore, public healthcare clusters. And I come from Jurong Health, which is the one right at the bottom here. And these are grouped by geographical sectors, right? So Jurong Health would cover Western sector, Sing Health, Southern sector, National University Central, Alexandra, and so on. They're all grouped by different geographical sectors, just like how the army companies and divisions are grouped. But that's how they did it. And each system, each cluster has its own resources for polyclinics and for long-term care facilities, but some had more and some had less. And those who couldn't really practice seamless care from cradle to grave. So the government actually started to merge the sectors together into 3 big sectors. So we are now grouped by these sectors now, right? So on the Western sector, we have NUHS, which is where I am now. On the Eastern sector, we have Sing Health, which is Singapore General Hospital with Changi, Eastern Health Alliance. And in the Central sector, we have Tan Tock Seng NHG Group with Alexandra Health Sector. And of course, we are building more hospitals also. Woodbridge Hospital is coming up, and Sengkang General Hospital is coming up. So 2 more new hospitals coming up in Singapore. And all these hospitals will then have the same facilities. They will all have primary care polyclinics. They would have long-term care facilities. They would have medical schools. They would have centers of excellence. And they are all equally matched now, in that sense, to provide seamless care from cradle to grave. And then we can really practice population health. And that's where the IT systems will come into, integrate all the different pieces together. Okay, so that was the only video that I have, and that was the most complicated piece. So the public healthcare system, just a cartoon to show you where they are grouped by the different sectors. So this is a breakdown of 1 mega cluster. Each of these mega clusters would have a general hospital, 2 or 3 general hospitals. In our case, National University in Ng Teng Fong. We have a ComHos called JCH. We have all the polyclinics are there, Bukit Batok, Poly, and Choa Chu Kang. And the specialty centers that we have in the western side are cancer, heart, and dental. We have a medical school called Yong Lu Lin Medical School with the dental school. So central cluster would have Dukes, and eastern cluster would have Lee Kong Chian Medical School. In terms of public healthcare spending, it's been going up. 10 years ago, Ministry of Health spent close to 2 billion on healthcare, public healthcare. And in a span of 10 years, 1 decade, that has increased 6 times. Our GDP has only increased twice, double. So you can see that our healthcare spending has outstripped our GDP in terms of pace of growth. And this is not sustainable. Having said that, we are only spending about 4.1% of our GDP on public healthcare, because Singaporeans still pay a fair amount of out-of-pocket money for their healthcare. So if you go to a GP, a family physician, you still have to pay cash. Even if you're admitted to the hospital, you still have a co-payment of cash. right? And of course, if you go to private, it's all cash, right? So, and a significant amount of our healthcare needs are fulfilled by the private sector. In terms of doctors, we have about 13,000 doctors registered in Singapore for a population of 5.5 million. In terms of the mix of local to foreign doctors, we have about 20 to 30% are foreign-trained foreign doctors. And that's because our medical schools couldn't keep up with the demand for doctors. And so we do have to take in a fair amount of foreign-trained doctors. We try to absorb those from Singapore that are trained in Australia and UK and bring them back to Singapore. In terms of the specialist and non-specialist ratio, about 60% are non-specialists, which are the family physicians, and 40% are specialists. So it's quite heavy weight on the specialist side. And specialists, by right, cost more, and they also drive a bit more cost more. If you're looking at health prevention is more important than treating. So by right, you should have more primary care physicians than specialists. So it's a bit overbalanced on the specialist side, even though we are 60-40. So the public healthcare sector handles about 80% of the acute care workload. That means 80% of our Singaporeans and people staying in Singapore go to hospitals for acute care, fractures, pneumonias, tumors. So 20% go to private healthcare, Parkway Parade, Parkway East, Parkway and Novena medical centers and all that. But in terms of primary care, 80% go to private because the polyclinics cannot cope with the primary care, so they go to see GPs, and GPs are by definition private in Singapore. So that's where they have to pay a bit of cash. And that's where sometimes the ministry has now recognized that we are giving too much money to acute hospital and giving too little to primary care. So they've come up with different schemes to try to disburse funds to primary care doctors now also. The good thing is that all public health institutions, PHI, have an electronic medical record system. So on the SingHealth Singapore General site, they have all scripts, which they have for the last 15 years. NSG, Tan Tock Seng, and NUH have the old homegrown system called CPSS2, which is end of life and will be sunset in 2 to 3 years' time. So Singapore is now on this project to find out which system these two clusters should use. And of course, Jurong Health has Epic, and I hope that the ministry chooses Epic for them for NUH and NUH, NSG. But that's up to ministry to decide. In the region, this is a short video to show you that Singapore spends about 4.1 of GDP. Thailand spends about 6.5. Cambodia 5.6% of GDP on healthcare. Vietnam 7%. Malaysia 4.1%, and Indonesia about 2.84% of GDP on healthcare. I think in terms of private expenditure of healthcare, Singapore, you still spend a fair amount on private healthcare. Because sometimes the public systems are overloaded. For those who can't wait, they prefer to see a private surgeon. That's Vietnam at 36% seeking private healthcare. Malaysia 35%. And Indonesia 46%. So one thing is for sure, the cost of healthcare is going up globally, not only in the region, and that's a worldwide phenomenon. And expenditure, percentage of healthcare spent on GDP is also going up. So that's not sustainable. So we have to find now we have to use different ways to try to make healthcare more targeted and deliver more bang for the buck. In terms of healthcare challenges, I think not only in Singapore, but we are faced with an aging population. So this is from the WHO website. So in Singapore, the average lifespan is 80 plus and climbing. And as you know, 11.75% in Singapore are age 65 and above. That means the working class is not able to support the aging population. We cannot generate enough tax to pay for the services required by the elderly sick. We've done well for certain conditions like cardiovascular medicine and for infant mortality and maternal mortality rates. But we can definitely do better in conditions like diabetes. We have one of the highest diabetes rates in the region, and that's because of our diet, our lifestyle, predispose us to chronic disease, and these things stay on for life and takes up a lot of healthcare resources. So chronic disease burden is increasing. We are having more patients getting older who have 2 or 3 medical conditions when they come to see us. So it's quite common now to see my patients with hip fractures or spine problems, and they are aged 70 to 80 years and above. So it becomes very difficult to offer safe, high-quality surgery for these people. Most of the best practices that we have in the Ministry of Health only prescribe for 1 condition at a time. They don't factor in for 2 or 3 combined conditions. So if you are osteoporotic, you should be taking a bisphosphonate and calcium. But if you have chronic renal impairment, that would preclude bisphosphonates, then we are stuck. What should we do then? There's no best practice for that. Medical knowledge is increasing at a faster pace, and physicians find it difficult to keep up. This is the amount of medical journals being published, and it shows that just in 1970 alone, there were only 200,000 articles per year. The year 2000, it was 400 over, and now it's almost 0.8 million medical journal articles published per year. So how is a physician supposed to keep up with all of these data and knowledge coming through? And that's a challenge also right now, because if you have been involved with a medical legal lawsuit and they look for expert witness, you have so many expert witnesses coming with different journals, and the judge sometimes is confused, what is happening here, and even it's difficult to advise patients sometimes because of all the medical knowledge. So we know that data does not equal to knowledge. Right? You have to make some sense of it. You have to connect the dots to derive something useful for yourself and for your patient. And we have an overload of data. And we are trying to use IT now to try to push best practice advisories and evidence-based medicine to the doctors in the forefront using IT. So for example, if you have a certain best practice on catheter-associated UTI, you would then want to advise doctors that this patient has a catheter inserted for the last 3 days. Is there a good reason that the catheter is still in there? If you can harvest the information on your microbiology in your hospital, you can then even advise the doctors what type of antibiotics to give for a specific condition, or empirical antibiotics to start. So the information should be analyzed, given to the clinician at the right context, for the right patient at the right time. That's theoretically the dream state. It's always a journey. So you can see a screenshot of our electronic medical record system in Epic. I've already blanked out all the information. But the idea here is a lot of information. It's a lot. So I came from a system before Ng Teng Fong was open. We came from a paper-based system where you use the computer to order medicine, order x-rays, order blood tests. But you do your documentation on paper. And that system was easy to use. None of us turned up for training, although we were supposed to go for training. You can find us in the canteen, but you go to the clinic later on, you figure out how to use the IT system, and it's easy to use. But now it's totally paperless. And I compare it with, if you use iPhoto in your MacBook, it's very easy to use. But if you start to use Photoshop, you need some training to use Photoshop. But it can do a lot of wonderful things if you can master the advanced system. So here alone, you can just see that you have data for your patient information board. It tells you where the patient is located, whether he's got an ACP, whether he's got drug allergies, whether he's got an infectious disease. All that is in the patient banner. Now, if you're not trained to look out for it, you will miss out things, and you might put an MRSA patient in the wrong bed. You might not know the patient has an advanced care plan and start to do a resus on the patient. You might not know the patient is Hep B positive if you didn't mouse over the caution. So users have to know what to look out for, because there's a lot of information just on the summary page. Here we have pop-up here called results management, and it's trained in all of us that if you order a chest X-ray, you better go and read the report because you ordered it, right? Of course, that's in a one-to-one situation. If you're in private practice, you treat the patient by yourself, so it's very easy. You ordered it, you check it, and if there's any abnormality, you act on it. But in a hospital in a team, it's more confusing because you have your houseman, your MO, your residents, your registrars, your junior consultants, and of course you. And then the patient could be having the X-ray ordered in ED, emergency department, admitted to orthopedics, but the results came back during orthopedics or when he was discharged, and then even more confusing. So all these things are, why the IT here is trying to remind the doctors, please look at your results here and acknowledge it so that we know that you've seen it, you've acted on it. And that protects the doctor because at least if anything happens, we've at least acknowledged it and it's a visual prompt. And all these things later on here, all the vital signs, you can look at the patient. And this is just the amount of data that's presented to every doctor using electronic system. You have all your lab reports, your radiological reports. This is, of course, the patient in ICU, so it's a lot of information to the doctor to digest. And we know that data doesn't equal to knowledge. We have to digest it somehow. These are the notes. So we use the very thick case sheets for ICU patients, but now they're all in the system. You have to figure out which notes you want to see. So there are nursing notes, therapist notes, doctor's notes, medical social worker notes, nursing. So you have to start apply filters if you want to make some sense of this. And those doctors who don't go for training class, they don't know how to use filters. Then they get lost in the information. And nurses will say, "Doctor, I write inside already, you never read." And then that's where communication breaks down. You say, "Oh, you never tell me." Then I say, "I write already, you never read." Then it's a circular argument. I say, "For important things, please talk. Don't rely on just the electronic system to document and to communicate." So again, some of the challenges when you implement IT systems, that people forget to talk. And they just assume that they've written, And so we are guilty of it as senior management. We write in the policy, and then the doctor never follow the policy. You say, "It's in the policy, you never read." It's okay. So it's quite same. Same. So you have to know how to use a system that is very powerful, because or else if you don't, you can't harness the functionality of the system, and then you blame the system, which is not the right thing to do. We do know that patients are getting more demanding. This is from the Singapore Medical Council yearbook, which you can download from our website. It shows you that the increasing trend of medical complaints against doctors, healthcare professionals in general, because patients are more demanding. And most of the complaints are related to so-called poor professional standards, communication errors, negligence, so-called. And the Medical Council has to vet through each of these cases. I mean, luckily, most of them don't go to court, and we try to do mediation to prevent them to go to court, because court is very expensive, takes a lot of resources. And most patients don't want to go to court because they just want apology from the doctor, explanation from the care team, what went wrong. And that's why mediation is a cheaper option. But the general thing is patients want to know more. They want to be involved in the care of their loved one, or they want to be involved in the care of their own condition. And IT, again, can support all these things by pushing it out to patient portals. So increasing healthcare costs, aging population, increasing burden of the chronic disease on our population, and therefore consuming more healthcare units. Explosion in medical knowledge, so it's not easy keeping up with current practice and best practices. We sometimes don't have time to read all these things, and we become very, very subspecialized, which is also a good and a bad thing. I mean, I'm a spine surgeon, but it's come to the point where if you have knee pain, I say, you have to go and see the knee doctor, because patient expectation is they want the knee surgeon to do the knee operation. All right, and similarly, if they have diabetes, they have a thyroid condition, they want to see the skin specialist, the endocrinologist, the relevant specialty, which also increases healthcare resources. and increasing demand from patients, and also doctors are under stress to provide good care, quality care in a timely manner. So Ministry of Health always tracks waiting time. They want to know how many % of patients are seen within 60 days of referral. So these are all operational constraints from the ministry when they work with the public healthcare institutions, that since they are funding us, they're giving us money, they want certain KPIs to be met. But these are operational KPIs. They are not patient-related outcomes. Okay, moving on into our IT now. There's an overview of the Singapore healthcare system. In Jurong, this is where I am, the EPIC Electronic Medical Record System. And that's a fully integrated system. It handles everything clinical. That means it's pervasive. It's from all the way from ED to the OT, to ICU, to the wards, to the SOC. It extends to our different geographical localities, like Jurong Community Hospital and Jurong Medical Center, which is our ambulatory surgical unit. And all things are there, the appointment system, the bed booking system, the drug information, the radiology, the labs, anything clinical. So it's one single chronicles database that is holding all this information. So previously, the old system had a separate lab system, they have a separate radiology system, they have a separate appointment system, separate documentation system, separate order system. Now it's all combined, so it's easier to manage the data, to extract the data for analytics. And it's all integrated also to these are all the interfaces. So EPIC is medical, but you have to integrate to all the other systems here, which is registration and billing. Ministry of Health uses SAP for billing and registration. So we have to register the patient here, pass the information to EPIC, and then EPIC drops a procedure code, and then the bill comes out from SAP. So that interface has to be done correctly, or else you get delay in billing or wrong billing, or even worse, no billing, which, when we first went live, we had problems with that interface. So we had some revenue leakage, which you have to urgently plug up. We are also linked to the outpatient dispensary, inpatient automated systems for medication, national drug allergy system, our blood bank, radiology, GE risk packs, lab analyzers, point of care testing, medical device integration, and a lot of other things. And this one is a big one. There's a National Electronic Health Record System. So that's where all public health institutions have to contribute to national EHR so that we can see each other. A patient comes from Singapore General Hospital to Jurong, I can see what happened in SGH. It's still not as rich as the full EMR, but at least we can see problem lists, lab tests, radiology report, and appointment and medication. So with these 5 things, we can figure out what happened in another hospital. Now, having all these things, it's useless if nobody is using it. Right? So we do track whether doctors are using the systems that we built for them. So we are about 99% for computerized physician and order entry. So we use this for our HIM7 staging. We are about 99% for barcoding, barcode med administration. So the nurses, no point putting a barcode system and then the nurses are not using it to scan for med administration. Right, so we are quite happy that our nurses are, in fact, our nurses are very compliant, better than our doctors. So they comply with the barcode scanning, and we also implemented the first blood administration, which is barcoded. So medicine is easy, but blood is different, harder, because we have to interface with a separate blood bank called HCLL, Hemocare Lifeline, American blood bank system, which is HSA approved. Yes, it's outside the hospital. It's at the National Blood Bank, and National Blood Bank use HCLL, so we have to use HCLL. And these are very specialized software that is FDA approved for blood bank, for blood products. So we have to interface with this system to do barcode scanning for blood administration. But happy to say that since we implemented the blood, there have been no wrong blood given to patient. But there was one near miss. One near miss because what happened is all this depend on barcode, the barcode on the patient. So patient went for surgery, they have to put IV line and they took out the barcode. So patient came back to ward, no barcode. And nurse is used to scanning. They don't even say, hello uncle, what is your name? And if the name of Tan is very common in Singapore. So Tan Kwan Xiang, Tan Yu Heng, you know, my name is Tan Yu Heng. And if patient, you don't ask patients, uncle, what is your name? And you just print the wrong barcode. So name become Tan Yu Heng, become Tan Kwan Xiang. And that's what happened. They scanned the wrong barcode. So that near miss. Hey, how come the blood didn't match? And then we found out the nurse didn't clarify a patient to patient identifier, name and ID number. All right, so even you have all the IT, you have to have humans that are still smart enough to follow basic protocol, okay? A lot of times, sometimes, you know, we have all the vital sign that is merged into the IT system, so you can see pulse, heart rate, temperature, and patient is sometimes sleeping, or we hope they are sleeping, and patient, doctors don't wake them up, they don't know, they say, oh, patient well, got pulse, got heart rate on the medical record system, but already patient died already. So you have to also interact with the patient. So IT doesn't stop you, doesn't help you to do all these basic things. In terms of documentation, what we are looking for is discrete data elements, right? If you can template your documentation, you can harvest the information for analysis, right? So H&P, history and physical, it's something that we enforce all housemen to use when patient come in, is admitted to the hospital. So their clerking is on H&P template. So they have to follow the SOAP, you know, what reason for admission, history of presenting illness, main complaint, the review of systems, the problem, the management. So at least it's templated for all the junior staff, and we force them to use that. So you can see that we have 90% discrete data which we can pull out from Epic to analyze. Of course, when you go to daily ward round, you use progress note, these are not templated. It's just free text. But at least it's free text, it's not PDF. A PDF you can't analyze, right? So you can still run natural language processing, which is something that we are thinking of doing, NLP, to help us the data there. This is a busy slide, but just to let you know that we integrated close to 1,000 medical devices into Epic. So they're pulling in information. The most common is BP, heart rate, pulse, temperature, SpO2. That's from the wards. But in the OT, anesthesia machine is also integrated. ICU, ventilators are integrated. Renal dialysis units are also integrated. So there's a lot of information for analysis. There was one time we had a patient pass away, coroner's case, so he had to undergo autopsy. And now we are paperless. The last time we just sent the whole case sheet to the coroner's office in Singapore General Hospital. But now we are paperless hospital. We print out for you a PDF file. The PDF file was 800 pages long, and it jammed the printer, the spool, you know, the server spool for 6 hours. Coroners said, I need to finish by 9 a.m. to give whether to undergo, to allow the body to go to for burial, because patients' relatives are asking, or should I do autopsy? And we had trouble. So we got into trouble with the coroners. They nearly complained to minister. This Epic system is too much. No? But what happened is that our mistake is we didn't filter and we gave them everything. So now we are smarter. For coroner's case, we only give them pertinent information. We don't give them all the 1 month history of all the ICU data, the operation, anesthesia, the ventilator. We take that all out. Problem list, labs, RADs, pertinent notes. We filter it, and it's only 10, 20 pages long. If they want to see the 800 pages one, we give them virtual access to the system. They can dial in VPN, and they can see it all they want. But we just want, most of the time, 90%, they just want the pertinent information. So again, it's something that we also sort of learned as we went along the IT journey. Too much data, and then most of it is noise. This is our iPass. I mentioned before, we have closed-loop medication management. And we know that after implementation of closed-loop medication, because this data is from AH, my old hospital where we are paper-based, after implementation of Barcode closed-loop medication management system, the medication error have decreased. And this is common across all hospitals who have done this project. So it's not something new. It's something that we know it's for a fact. The thing is that when it costs money to implement this. And CFO always asks, why do I need to pay for this? Do I earn money from this? But so we always tell them the cost. So it's theoretical. What's the cost of one adverse drug event? Most of the time it's nothing. You know, patient get a rash, and then they go home. But if you get one Steven Johnson, touch wood, we haven't got any Steven Johnson. But how much is the cost of that? Maybe a few million. But it's all theoretical. You know, if you buy an MRI machine, your ROI should be in 3 years. But if you invest in iPass, what's my ROI? That's actually harder to define your ROI for IT sometimes. It's life, yes, safety. But but if CFO say, I want hard dollars for your projection, that one is tough. But I think we have understanding CFO. I mean, that's why we have managed to get all these things. They also understand. So it's very important that your senior management and your board understands why we invest in IT, because safety and quality sometimes doesn't have a hard dollar amount. And I'm quite blessed to say that most of my senior management, they are aligned with this vision. So as mentioned before, all the different accolades, but the most important to me is the HIMSS MRAM stage 7 for inpatient that was achieved last year. So a lot of people said, what's so good about HIMSS MRAM model? It is a standard that's international that we can aspire to, I think. Because if everybody say of IT, but what IT are you talking about? Is how do we measure and gauge the IT that you have in your system? Is your IT just basic, or is it able to collect data to help you improve your workflow and your safety and your quality of care? So at stage 7, you have to demonstrate that your medical record system and your analytics team is able to do that. You have to demonstrate 3 case examples in which this has been done, and one of which must be financial. That means you had financial gain from the IT system. So the finance part was the hardest, but we managed to show something for that. And stage 7, it's only 4% of hospitals globally. Not many have achieved it. And every 3 years, you have to recertify, and every 3 years, the standards go up. So the last one was for stage 7 is you need to have barcoded blood administration. That's something new, which luckily we managed to clear. But we're not sure for 2 years' time when we have to recertify what will be the new requirement for recertification of stage 7. But the idea is that stage 7 means that you can collect data for improvement. So I'll just go into some case examples of how we use our IT systems to improve patient care and also to make care safer. So mentioned before, it's in the old system, it's pieces of paper everywhere. You have nurses running around, putting BP and heart rate on paper, then finding the vital signs chart and transcribing it in. And the job of the junior doctor every morning is to go and hunt for the case sheet, hunt for the medication chart and the vitals. And these 3 pieces of paper, you can then start ward round for this patient. And then the nurse, if you finish your ward round late, you clash with the nurse who want to serve medication, and they want the medication chart. So now everybody can access the medication chart at the same time on the EMR. So as I mentioned before, we've integrated all our vitals, and what are we doing with this information? I mean, no point just putting into the EMR and just letting it stay there. The coroners don't even want to see it. So we actually use it for our early warning system. So we capture about 500,000 vital signs every month into our system. 15 vitals a minute. So for the nurses, this is a good thing because they don't have to run around transcribing. It's all uploaded into the system straight away after they measure the system. And theoretically, you've saved 10 nursing FTEs, right? You can deploy these nurses elsewhere, and they can do more direct patient care. So there's actually a dollar sign there. ECGs are paperless, so we save trees. We do not print ECGs now, and each of these ECG strips, the pink paper is $1.40, about US $1. Since go live, we've saved about 150,000. So again, that's a hard dollar that we have saved. Other things like MRO space, we don't have paper charts anymore, so we save a lot of space for medical record office also, which can be redeployed to clinical, to revenue-generating clinics. And then vital signs. So this is how the nurses do it. They barcode scan the patient to capture the ID, take the BP, heart rate, the SpO2, temperature, they have to do it manually. You key in the temperature after reading it off the thermometer. And then after that is pumped into the EMR. The EMR will start doing its maths, and then you come up with a Jurong early trigger system. So this is traffic light system. So green means patient is good, yellow not so good. Of course, red is critical, and black means patient is code blue. All right, so we've made it simple for the nurses. But it's good. So at a glance, they can tell in the ward, the nursing officer can tell in the ward which patients need more care. You can redeploy the nurses according to the area of need. And you can see it both in the medical records, you can see it in the dashboard in the nursing officers, and of course you can see it drill down here also. So in fact, now the nurses says, can we make it better? I said, how we want to make this better? We want the system to press the code blue button for us. I said, okay. Wow, then how you do need to think already? Okay. So they wanted to do this, that when they measure the BP, heart rate, and SpO2 of the patient, and the patient is comatose, it will automatically send code blue system through our IP-based phone call system to the code blue team in ICU. I said, okay. We had a big argument on that. I said, are you sure you want the system to make the call? I'm sure you nurses know when the patient is dead or comatose, right? Or dying, right? It's like, oh, okay. So anyway, they won the argument, and I said, okay, we'll do it for you, but maybe I'm traditional. I think maybe the IT shouldn't be doing too much. But anyway, we'll build it. So FY17, that's our project. Enhanced JET score, which is automated. Once the patient is code black, when it becomes a black dot, means code blue, the code blue team will get automatic phone call on their phone to rush to the ward. So hopefully we're going to study whether that will be useful. Too many false positive or false negative. We'll see what the effect of that study is. But this is how we are analyzing and using our data for secondary use. We also have alarm fatigue, right? So sometimes you have too many alarms, right? And what we have done is we are going to personalize the JET system. So for example, in ICU, and the patient is always hypotensive, the ICU registrar or consultant can lower the BP threshold for that patient. So you're not always alarming, okay? And you decrease your alarm fatigue. When that alarm goes off, then you know you're in trouble. So that's personalized alarms. We also save on blood redraws. What I'm showing here is when the doctor takes blood, for example, he takes a full blood count, and now he wants to add an ESR. The system will prompt the doctor, you want to add on? Okay, so within 2 hours, you can do an add-on test. And that saves the phlebotomy charge, that saves the patient another painful injection. Okay, so that's something good. Epic will prompt them. And why you see this drop here, because when we first turn on the system, we allow up to 6 hours to add on tests. But the lab people complain that every time you do an add-on test, they have to look for the tube in the lab analyzer, which consumes their time. So they prefer you redraw the blood. So again, sometimes IT can do, but people, we have to speak to people and understand their problems also. That we are. So we actually decrease the threshold to 2 hours, so we don't stress our the laboratory too hard, or else you have no lab people at all, and then that's even worse. Right? So we dumb it down and we allow. So that's why you see a drop here. So now we do about 1,586 add-on tests. We can do more, but it strains the lab medicine. So we save $21,000 in phlebotomy charges for patients. Of course, this is loss of revenue to the hospital. Hospitals say, hey, I want to charge people, so my phlebotomy service can earn money. I say, we are saving patients money, okay, so can we be rewarded for that? That has a different discussion with CFO. We save 1,000 extra pokes for the patient. Okay, so again, doctor is prompted, you want to add on? Okay, so you can add on. 6 minutes ago, you just took the blood. You want to poke the patient again? Okay, so it prompts them. This is some slides on the transfer from an acute hospital to a community hospital. So previously, we were in Alexandra Hospital, and our community hospital was called St. Luke's Hospital, which was about 5 kilometers away. Now, with an integrated system, we are linked by a bridge to our ComHos. And better still, our medical record system is the same. So the community hospital doctors knows that we have a hip fracture patient being operated today. They can actively pull the patient once the drains are out, and they can just see that. So their case managers actively monitor the hip fractures, and without calling them, they will come and say, is your patient ready for transfer? So the average transfer rate for other ComHos is about 6 to 7 days, but in Jurong, it's about 2.8 days. So this is not entirely due just because of the EMR, because also we are co-located. And we are seeing similar results for Khoo Teck Puat and Yishun ComHos. They are achieving similar transfer times also. So the faster your transfer time, the better it is, because you can free up your acute beds for more acute patients. Currently, our bed occupancy rates in Singapore are running at 90 to 95%, which is a bit high. But once you hit 100%, you have to start cancelling elective cases. And elective cases bring in money, right? So that becomes a serious problem. So that's why we try to transfer as many as we can to the community hospital as soon as possible. So previously, we have to go to AIC, Agency for Integrated Care, to transfer patient to community hospital, but now we don't have to. We just have to go through direct. We bypass AIC, and then we just direct transfer to ComHos, Jurong ComHos, but we do inform the Ministry of the transfer so that they can track the workload. So the wait time for transfer is less than 2 days, sometimes even 1 day. With an integrated care path in Epic, we also can cut down the length of stay for hip fractures. So in AH, with a paper-based care path, it's about 12 days, and about 10 days with an electronic care path. Because the electronic care path can remind doctors that they have not done certain things, like they have not referred to physio, they haven't referred to social worker, please do it. They have a traffic light system also to alert the staff what they are deficient in. So it helps them because there's so much information on the system. The system prompts them and guides them along, especially the junior staff who are rotated every 4 months. They come from another hospital, from a different unit, from general surgery, from medicine, and they come to orthopedics. It's a whole new world for them. So with this, they are able to guide them, please do this. If you're not sure, you can. The system will prompt you, provided they read the system. This one is to show you we have a lot of information in the IT system. I mentioned before, all the clinical stuff is in Epic, and all the billing and registration is in SAP. So you put it into the data warehouse, you get noise. So then you need to employ data scientists. I'm not a data scientist. We get data scientists to make graphs for us. So then, oh, okay, this makes sense. Now we know what that data is. When we combine the cost data and the clinical data, we do know, for example, in this one, we identify a problem. So if you see the graph on the left, we see that for our hip fractures, we are charging them only on the 6th day of their admission, when the operation happened on the 2nd day of the admission. So why is the billing information coming in late? And totally, who are electives, we charge them on the 1st day of operation. So that's correct. So from this, we can tell the nursing officer in operating theatre, there's something wrong. Do you want to look at why your nurses are not dropping charges appropriate time? Because you're getting delay in billing for the patient. So with EMRs, you have a microscope, and then you start uncovering problems. The only thing is whether the staff are willing to accept there's a problem and willing to change now that you've identified a problem. So sometimes they don't like, they say, oh, why are you going to tell me this? Now I have to fix it. Right? But most people, I think once they know there's a problem, they want to fix it. So with this, we can now guide them how to fix the problems. We also can give you very granular data. So previously, when we calculated length of stay, it's, on average, $1,000 a day for a hip fracture. Right? But now we can tell you on day post-op phase, the length of stay is only $200 a day. It's not $1,000 on average. We can give you day-by-day granular data, so the billings for the patient. This is a nursing documentation. Again, how do we help our nurses? We have about 3,000 nurses in our system, and they have a lot of work to do. And one of the things that they have to do is documentation. All right, and here we see a flow sheet. So doctors like to use progress notes because they just like to type, but nurses like to use flow sheets. And in this flow sheet, you can see that the nurse is guided on the phlebitis score. They can see, is it 1, 2, or 3? And what does 1 mean? 1 is initial stage, medium, and advanced stage, 1, 2, and 3. And then they are guided as to what to do if they see initial, what to do when they see medium, and what to do when they see advanced. So we can guide the nurses as to what to do if they're not sure. I'm sure they're trained, but again, information overload. So we give them contextual help as to what to do when they see phlebitis and how to document it. And nursing officers can also track compliance. Are your nurses checking the drip sites? Are they doing the phlebitis score? Why are they not doing it? And who is not doing it? Who's in charge of this cubicle? Why are your compliance rate low? Right? So they can track them and they guide nurses to provide better care. And falls prevention also. So we have a fall score. The nurses have it. And the MOS fall risk score. And once you enter all the different components of the score, system will calculate the score for you and then trigger certain advisories for you. So if they're high risk, system will say, please refer physio, institute patient education on fall risk. And then the nurses they can sign off the forms. They can sign off the physio form. So we allow nurse to refer physio. Previously, last time, we said only doctors can refer, but now we say, nurse, please refer to physio by yourself because your falls is high risk. Don't wait for the doctor to come. And then you also start to institute patient education to patient and to the next of kin. And you document that you've done the education. And in the new version of EPIC coming up end of the year, we are doing an upgrade. They will also give you medication education because now a lot of patients have polypharmacy and they need to know what each of the tablets actually mean. At least the next of kin should know what medicine causes drowsiness, what medicine may cause gastritis, and what is each of the medicine for, because that's very important. And patients want that, or the next of kin want this. They want to know what the medicines are, and actually, if you teach the next of kin, they are very helpful because they can guide you in your medication reconciliation. Because most of the patients we have are very old, they don't know, but the children will know, and they are a great resource if you empower them with the knowledge. This is a discharge checklist. Our chairman medical board always said, please discharge by 12 p.m. because new patient is coming up by 1 o'clock. Those from the OT, those from the ED, they are waiting. So always we have to try to discharge early. And with the new version of Epic, we can have a traffic light system also. It's a checklist. They call it a passport. And you have to fill up all the components of the passport. So you have your medication reconciliation, your discharge summary, your appointment booking, your medical cert, has it been generated? Have you dispensed the medicine? Has the pharmacist given the medicine? And so on and so on. So your nurses can then start to chase the houseman or chase the pharmacist. A patient is going home soon. Have you done this? Can you quickly finish your summary so we can discharge the patient? All right? And hopefully this will help them to drive workflow in the wards. And another good things for nurse, we have a lot of wound nurses because of the diabetic foot population. And previously they couldn't store the picture in the system. They store it in the progress note, which is not so useful. They should have actually stored the picture in the flow sheet so we can see over time how the wound is healing. Because if you store in the progress note, I just showed you the progress note just now, it's a mess. You can't see the progress note sequentially in a timeline. But for nursing flow sheet, it is perfect. You can see the timeline. And 1 week, 1 month, 2 months, 3 months, how is the wound is coming along. And with the new system, we can then put in the pictures in the flow sheet. We're also trying to, if we have enough money, right now, not enough money, trying to get mobility applications. That means a handheld device for nurses to, instead of using a very heavy computer on wheels, we are trying to arm them with a mobility device. So they can take pictures, upload to the system. They can do barcode med administration. They don't have to bring the heavy computer on wheels to the bedside. They can do vital signs. They can even do their flow sheet documentation on these small devices. And this is how the application looks like on a phone. And of course, if you can pair it with a barcode reader, then it becomes, you can do your barcode reading. Of course, the problem is cost again. And every time when we bring this project up, CFO want to know how much money we can earn with this. So we always say, no, you can't earn money, but you have efficiency, safety, and it's a bit harder to give the ROI on that. But it's something that, we couldn't have done if we didn't use a software vendor. There was always this big discussion in Singapore whether we should build our own system, whether we should, like Hong Kong, or whether we should just buy off the shelf and customize to our use. And I think, to me, I think buying off the shelf is easier because you let the vendor do all the application development. You just customize for your own use and you focus your time on clinical care and direct patient care. This is just a summary page of what UCLA has done. UCLA also uses Epic. Their CMIO used to be Chris Longhurst, is now CIO at San Diego. And what they did was that they customized their summary page. So you saw my summary page. It was quite messy. We haven't had time to clean it up. But they made their summary page such that it tells a patient story. So on this summary page, the doctors and the nurses will know how long the patient has been staying here, what is his expected discharge date, what are his reasons for admission, what are his medical problems based on SNOMED ICD, the goals for this shift, in this case, use toilet with assistance, learn full bed exercises, and what does the patient want? You see, I want getting to know me. I prefer to be called Mr. Reddy. I live in Minneapolis. I like reading, and so they put in all these little things that mean something for the patient. Which is something I think it's the touch is good for the patient. So it's not only you can customize a page for clinical, you can also customize to get to know your patient and what is important to the patient. Moving into the realm of predictive analytics, this is something that is quite high high technology stuff. I don't know how they do it. Our data workers use this. So this is published in Singapore General Hospital. They use a LACE score to predict readmission using their IT systems. And here's the receiver operator curve, area under the curve. The further up here you are, the better it is. Down here is no good. So SGH said that they're doing quite well with their system in terms of readmission. In Jurong, we have a REPER score, readmission predictor score, which is calculated real time in Epic. Previously, we had to do it on paper, and then it's not real time because it will come out in Excel spreadsheet. Then your case manager will have to see the Excel spreadsheet and then find out if this patient, where is the patient, and then they will, look for the patient to do some intervention for prevent readmission. But now it's real time. So this one is low risk, so don't need to do anything. And this one is high risk, so you have to do something. And your case manager will have a report here to identify where all these high-risk patients are, so they can go and start hunting for them, getting social services set up, calling them after they're discharged to make sure they're okay, taking their medications, are they all right, to prevent readmission. So this is something predictive. We just rolled this out 6 months ago, so we're still collecting data and in doing our internal validations for our REPER score. But the current ROC curve, receiver operator curve, looks better than the other one that we saw previously. So we're quite happy with this. But this is something that we are still validating after 6 months. We still need more data to validate the REPER score. Other forms of clinical decision support that we have, we all know drug allergy, so that's something simple. You can do duplicate interaction checks. But we also have the urologist who come in who has a passion for catheter-associated UTI, and he came to us and says, Dr. Tan, can you help me to do an advisory for catheter-associated UTI? Because I get a lot of referrals with UTI, and it's due to people putting in the urinary catheter and forgetting about it. So I want the doctors to be reminded how many days it is in there and to be irritated until they take it out. So we built something for him. So if you put in a catheter for more than 3 days, a pop-up will appear on your Epic asking you why is the catheter still there. And you cannot go away until you give a reason. So it reminds them, please take it out if it's still not needed. Our ASP, Antibiotic Stewardship Program, that is something that is funded by the Ministry of Health, and we do know that antibiotics and resistance is a big problem globally. So Ministry of Health says we want to control your use of antibiotics, monitor it, especially for the high-powered antibiotics. So we are monitoring the imipenems, the penem group. All right. So this one is what we call we call it EASY. That's our antibiotic stewardship program, and based on the data that we've seen, those doctors who listen to the antibiotic stewardship prompt the system will prompt you. For example, you put in pneumonia or you put in urinary tract infection in your problem list. The system will prompt you what antibiotics to give, and if you deviate, you have to give a reason. And then you will receive a call from a very fierce infectious disease doctor or her pharmacist asking you, Dr. Tan, why are you not listening to EASY? And then you say, okay, next time I listen. Okay. And the good thing is that overall length of stay is better for patients on the EASY program. I'm not sure why, but we're still trying to validate why patients stay shorter if you follow the antibiotic stewardship program, but there it is. Again, you need people to drive the system. You need pharmacists to look at the scores and to call up the doctors. Okay, so average length of stay decreased by about 5 days. If you want to put a dollar value to this, you can. 4,900 bed days saved. That's a dollar value for CFO. And then we could have treated more patients with these extra beds. Other ideas that we're looking at, I've already shown you the fall predictor. We are also trying to come up with the outpatient no-show predictor score, because our no-show rate is about 20 to 30%, which means that most of the time you overbook by 20%, and then if everybody turns up, you're in trouble because you've got too many patients. And then we're also trying to come up with a DM risk score predictor. So we are working with Tan Tock Seng for this, because sometimes the hospital Jurong is small. It's only a small hospital, but Tan Tock Seng is double our size, 2.5 times. So sometimes you just need ideas. And then using the ideas from other hospitals, you collaborate and come up with new projects. Another project that we are working on is value-driven outcomes, value-based healthcare. They're all the same thing, where we are trying to give a value index to the care that we provide. As you've seen, the cost of providing care is getting more. And ministry wants to know, what are we paying for? I guess patients also want to know, what am I paying for? Why is this knee replacement or spine fusion more expensive than the other guy? So we are measuring quality, we're measuring costs, and all this is in the data warehouse. So these are some of the parameters that we are looking for the quality side, whether there's good quality care, the unscheduled readmission, unscheduled return to OT, length of stay, surgery within a certain timing, deep vein thrombosis prophylaxis, blood transfusion. We also ask the patient, how are you feeling? How's your SF36? How is your knee society score? How is your overall patient experience score? So we put all this into the system, and then we plug it together with the cost data to give a value index. So this is just some of the preliminary data that we're getting from Jurong for the amount of blood transfusions for knee patients. Of course, the less, the better. And how many of our patients are compliant with DVT prophylaxis. And then the cost of TKRs at the 50th and 90th percentile for our hospitals. So of course, these are all not validated. We are just starting this project. So this is just for illustration, but this is our initial data cut. And reports need a lot of validation. So the VDO project would allow us to track individual surgeons. What type of implants are they using? Are they costly or are they normal implants? Total cost of care for your consumables, for your facility costs. And then we can come out with the value index, and hopefully we can try to change human behavior, because it's very hard to change surgeons' behavior to use certain implants, right? And Ministry of Health is also trying to put a bucket of implants, like for knees, these are the 15 or set of implants that we subsidize. If you want to use something different, you ask the patient to pay more. Similarly for cataracts and for cardiac stents, they want to have this group purchasing and try to contain costs of implants, which are very expensive. Okay, this is something I think we are dealing, it's a kind of something we're dealing with right now, results management. So from young, we know every time you order a test, you must review the result, right? So that's basic. Departments also need to have a workflow and a process to instruct doctors how to review results. For example, inpatient workflow, housemen to acknowledge results on summary page in the morning round and the afternoon round when they go home, the exit round. That is something we always tell them. And it's written in a department policy. Outpatient results management must clear your in-basket within 2 weeks of the results coming in. So it's all written down. So they cannot say they didn't know, because it was given during the department briefing. We also have a process to monitor whether they are compliant to this workflow. And we have IT tools and enablers to help doctors to achieve this goal. So we not only tell them, but we also show them this is how you will do it. All right, so for workflow, outpatient results sent to in-basket. Please clear it. It is mandatory to clear your in-basket. You can ignore your email, but you can't ignore in-basket. Inpatient is presented to you in the patient summary page for daily review. And once the patient goes home with an unacknowledged result, it goes to your in-basket. So again, go back to your in-basket. So that's something we have to keep telling the doctors. Please clear your clinical in-basket. You can also review your results in chart review tab, results review tab, and reports. So we have so many ways to acknowledge results. So there's no excuse. provided you go for training, because if you don't go for training, you won't know how to use these tools. So this is just a snapshot of our in-basket. You can see that in-basket has a lot of things. You have results, open charts, that means those are the ones where you pended your note and you haven't finished typing it, or they are lacking a problem list, because we mandate that all encounters have a problem list also. Why is the patient here? Case messages and all these things here, but the most important are results. So once you click results open, you can see all the results you have to acknowledge. If you don't feel that the result belongs to you, you can forward it to your friend, who if you think that he is the one who is in charge of this patient. So sometimes you have to also define the rules of engagement, because we had argument with ED, an inpatient doctor, that ED ordered the X-ray, but the report only come back next day, because the X-ray done at midnight, but the report come back at 12 noon the next day. But the patient is in the ward already. And then the ward doctor say, this is not my report. You go back to ED. So we have to teach doctors that when the patient is under your care, at that point in time, the result is yours. You are accountable for it, even though it's ordered by ED. Or else you have this big merry-go-round of results forwarded here, forwarded there, and no end to it. Now, if you feel that this result was ordered by endocrine, because endocrine ordered a cortisol test, and now it's come back and patient is under orthopedics, then please call the endocrine doctor and say, result is back, what do you want to do? But please don't leave it unacknowledged. Acknowledge it and act on it. Don't leave it just sitting in your in-basket. This is the inpatient workflow I showed you. So again, if your cortisol results came back ordered by a different department, please acknowledge it and call the ordering doctor. And that's why the houseman is there, right, to do all these things. For HODs, you can see who is the naughty doctor, right? So you can run a report to say unacknowledged results by consultant. So we don't go for the houseman, we go for the consultant. Because housemen leave every 4 months. Residents leave every 6 months, so no point chasing them. You have to go for the consultant and make them accountable. So we can see this one, 165 results, and then we can bonus affected. So we have 1 month bonus allocated to quality. So if you don't make your quality score, HOD or Chairman Medical Board can decide to take away 1 month bonus. Okay, so that's a lot of money. All right, so we tell them, please review your results. So far we haven't done it yet, but we threaten them to, we can start doing it if you don't want to listen. Now, this is a high-risk chest X-ray report. I'll just read the report for you. Chest X-ray report shows 3.7 by 3.5 cm opacity lobulated margin, right upper lobe. Suggestion of subtle bony destruction involving the inferior aspect of the right fifth rib. Further evaluation by CT scan, thorax is suggested to rule out malignancy. Now, if you didn't see this report and you only saw it 6 months later, what are you going to do? And then you open the Epic and you say, hey, this patient didn't come back for follow-up, nobody else noted it, nobody acted upon it. You go inside the National Electronic Health Record and say, hey, he also didn't go and see any doctor. That means this guy doesn't know he has this possible metastatic lung cancer or lung cancer. So we have had this happen before. It's common. I mean, you can ask, most people don't want to tell you, but yes, it's very common. And these are the ones where you have to contact MPS and contact your lawyer, your medical legal team, before you even call the patient. And what are you going to tell the patient? Sir, I routine check. I saw an X-ray 6 months ago that I think you should come back for a scan. And they will ask you many questions. Why? Why? Why now? Why 6 months? And now my father is dying from stage 4 cancer. How are you going to compensate me? But you ask of course you ask the oncologist, they say even 6 months ago it's already metastatic, so no difference. But the patient don't care. It was missed. And we have to settle out of court. right? And this is what happens when you don't clear your in-basket, when you do not do your results management. Okay, so this is an example of a high-risk chest X-ray, and of course you have to ask the X-ray department, why can you, if you see this kind of cases next time, can you give us phone call, right, or drop us email? Because for critical results, we get alert through SMS, through automated SMS, but this is not a critical result. Critical result is pneumothorax, necrotizing fasciitis, spinal cord compression. Okay, so that's critical. This is not critical, not life-threatening within the next 24 hours. So but it is a highly abnormal, significant result. So we have now worked with our radiologists, and they finally agreed that, okay, we will highlight these cases of potential malignancy to youth on chest X-ray. These are the kind of cases that you would prefer to have a high false positive rate than true positive. So we detected in the system about early Feb that there were 16,000 results not channeled to in-basket. And this just recently. Because through some algorithms that we made during Go Live, and it wasn't validated, and 16,000 results were not channeled to in-basket. So this is live. I mean, this really happened, I mean, if you look at it, we process 2.1 million lab results every year. So this is 0.6% of the whole thing, but still, it's still very bad. All right. So when we detected it, it was a crisis. I mean, the good thing was that the results were still visible in the patient chart. So if the doctor had been dutifully running his reports and also checking on the patient chart directly on the summary page, it's there. It's not that you cannot see the result. You can see the result. It's just that it didn't go into in-basket. In-basket is like the last line of defense. And doctors were getting reliant on in-basket. They said, never mind, you're going to my in-basket. It's okay. I don't need to acknowledge now. You're going to my in-basket. But we detected 0.6% didn't go in, 16,000. And so the first thing was, when we detected it, is to have an immediate stopgap. All right, so we mobilized a team, the EMR team, and we said, okay, quickly stop all further errors. That means I want you to manually now take over command. That means turn off the autopilot. Manually channel every result to the in-basket now. So for 1 week, they were pulling on 12 midnight shifts. Yeah, it's not nice, but what to do? They had to stay back and make sure this is the problem, it's our problem, we will fix it. We fixed the routing logic within a week and put it into production. And then we had to reroute every result in the error pool into in-basket manually. And then we had to quickly tell CEO and senior management, HODs, directors of service, something bad happened. We have to confess what we did or what we didn't do, what went wrong, inform medical legal team and medical affairs, come up with a workflow to recall affected patients. At the end of all that, we still haven't done our root cause analysis and learning process, because we're just dealing with the crisis now still. Okay, so as of now, we have sent out all 16,000 results to in-basket, and we've got 80% acknowledgement rate of these 16,000 results, and potentially 3 to 4 medical legal cases we have further investigation. In fact, today my CEO said, where are you? I said, I'm in Bangkok. I want to see you at 6 p.m. To update me on result. Then I said, sir, cannot. My flight is at 6 p.m. It's okay. So it's okay, he understands. Deputy CMIO is there. I have a very good deputy CMIO. I said, sorry, Kevin, I have to burden you with these things. I wish I could be there. But it is something we see all the time in medical, not in IT. Medical, where accidentally have a dural tear during surgery, accidentally fracture a bone inserting a screw in the osteoporotic bone, and we have to tell patients, sorry, something went wrong and I have to fix it, and it might have some permanent damage, and I think that same ethos flows to everything that we do for the care of the patient. Once the error is detected, we have to own up, do open disclosure, and be truthful about it. And the moment you want to hide, then that's when the problem will start. Okay, so that's something that's a learning journey for us. IT, in summary, it's necessary for any learning organization. Why you need IT is to collect discrete data elements for secondary analysis and use, learning, improvement, and safety. Without the data, you can't improve. If you can't measure it, you can't improve. Now, we are needed here to provide the heart. So I like your team. Your team is inner power, together we can. I think that's very important, because when the crisis hits, it's your team that will stand behind you, whether senior management or the EMR team. And then we need the brains to execute the work plans and the workflows. And together with all the HODs and directors of service, we need to mobilize them, and they need to understand why we are doing this. Now, the organization also needs to help to support the doctors and health workers in the time of when they are in trouble. If they're telling you, I'm overworked, under-resourced, we have to effectively staff them together as one, and then we have to play together and celebrate together. So last night I bumped into I think there was an award ceremony for the health assessors. So it was quite touching to see them. They were getting all their best surveyors awards from CEO. So it was a very touching thing. And then when mistakes occur, you have to recognize and own the mistake. Accountability, that's important for healthcare providers, I think for any industry. And then let your senior management know that something has gone wrong, because you need them to help you to fix the problem. Inform patients, support the staff, because the staff are also traumatized. They are also victims also. And we are also sometimes also traumatized with, and we have to learn how to cope with these things. Learn and improve and share the knowledge, share the knowledge, so others don't make the same mistake. Okay, so